Iron deficiency anemia is the most common cause of anemia worldwide. It is caused due to reduced iron in the body, which forces reduced hemoglobin synthesis. When we classify anemia based on mechanism, it can be divided into anemia due to blood loss, anemia due to reduced production of RBCs, and increased destruction of RBCs. Iron deficiency anemia comes under anemia due to reduced production. Also, in chronic blood loss, iron deficiency anemia occurs. So, iron deficiency anemia can be placed under different baskets when we classify anemia based on mechanism. In this video, we look at the pathology of iron deficiency anemia, causes, investigations, and clinical features. I'm Nabeel. This is Pathologist. Iron in our body can be divided into two pools: the functional pool and the storage pool. Functional pool includes iron in hemoglobin, myoglobin, and iron in some enzymes, while the storage pool mainly includes ferritin and hemosiderin. The functional pool is way more than storage pool, but whenever there is an iron deficiency, the storage pool reduces first. So, ferritin is one of the earliest indicators of iron deficiency. Iron is absorbed mainly from the duodenum. Imagine this is an enterocyte, and this is iron. This iron, which we get from food, will be absorbed into the enterocyte. This iron from the enterocyte cannot directly get into the blood circulation. It requires a portal or a channel to go from enterocyte into the blood circulation. This portal is called ferroportin. If ferroportin is present, iron from the enterocyte goes through ferroportin and enters the circulation. Iron cannot be left free in the circulation as it's dangerous. So iron is bound to a protein called transferrin, which takes iron to the liver and the bone marrow for storage and production of hemoglobin and RBCs. Body has only one method of regulating iron metabolism, that is hepcidin, which is produced by the liver. Hepcidin inhibits and sort of destroys ferroportin, thereby preventing the dietary iron from entering the circulation. And when ferroportin is destroyed, the dietary iron remains within the enterocyte, and when the enterocyte dies, it falls into the duodenum. This is how iron is regulated in the body. So, hepcidin is considered as the master regulator of iron. We'll talk more about hepcidin in anemia of chronic inflammation. Now let's look at the causes of iron deficiency. Iron deficiency can be caused due to reduced intake of iron, or it can be due to reduced absorption of iron from the gut. It may be due to increased requirement or due to chronic blood loss. Reduced intake can be seen in vegetarians or infants fed on breast milk, as breast milk is a poor source of iron, or old debilitated patients who are not getting adequate nutrition, or due to poverty where the quality of food may not be adequate. Decreased absorption of iron may be seen in conditions which affect the duodenum like celiac disease. Increased requirement of iron is seen mainly in pregnancy or due to growth phases like in teens. Chronic blood loss can be from the GIT because of ulcers of the stomach or lower GIT tumors or parasites, or due to menstrual blood loss. Worldwide, probably chronic blood loss is the most important cause of iron deficiency. Whatever be the cause, all of these finally leads to reduced iron stores. Now let's look at the morphology. RBC contains hemoglobin, and hemoglobin forms the major bulk of the cytoplasm. If hemoglobin reduces, size of RBCs reduce. Also, since hemoglobin is the main thing which gives color to RBCs, the pallor, central pallor is increased. So what you get is small sized RBCs with reduced color. They are called microcytic or small sized, hypochromic or RBCs with less color. So in iron deficiency anemia, you classically get microcytic hypochromic anemia. Along with that, you get differently shaped RBCs, classically something called a pencil cell. So you get RBCs of varying sizes and varying shapes. So this is called anisopoikilocytosis. Now let's look at the investigations you do in a case of iron deficiency anemia. As we saw earlier, ferritin, the storage form of iron, is the first parameter to go down in iron deficiency anemia. Along with that, serum iron goes down. Transferrin, which transfers iron, will have less iron to carry. So, serum transferrin saturation goes down. Total iron binding capacity is the capacity for transferrin to bind to iron. So when the iron levels are less, the capacity for transferrin to bind to more iron will increase. So total iron binding capacity increases. And finally, in peripheral blood smear, you get microcytic hypochromic anemia. Clinically, most of the patients with iron deficiency anemia may be asymptomatic. When you examine, classically you see pallor, and some patients exhibit spoon-shaped nails or koilonychia. Pica is an interesting symptom which occurs due to iron deficiency in the central nervous system. Here, patients start feeling like eating mud and soil and raw rice, etc. Long-standing iron deficiency can lead to heart failure. Also, increased tendency for infections. So we learned that iron deficiency anemia is caused due to reduced iron in the body, which leads to reduced hemoglobin synthesis, because of which we get microcytic hypochromic anemia and reduced ferritin levels in the body. And clinically, you may get pallor, koilonychia, heart failure, etc. Also, we had learned that hepcidin is the master regulator of iron. In the next video, we look at anemia of chronic inflammation where hepcidin plays a major role. Please check the description for the post-class quiz. Think at the cell level.